So I'm happy to be here today, and I appreciate you all coming out to hear me talk about this topic. I'm the coordinator of the Cancer Genetic Counseling Service here at Karmanos, and we now know that in a small subset of families, the likelihood of developing cancer is actually running in the family. It's what we call hereditary. And through a blood test, a genetic test, we can determine who may be at risk for these hereditary cancers. But is genetic testing appropriate for everybody with a personal and/or family history of cancer? And if we think it's appropriate, which genetic test do we perform on these individuals? Those are just some of the topics that we're going to talk about today. And so my objectives today is to review hereditary cancer and what we really mean by that. So I'm going to take you back in time a little bit and review some basic biology concepts, because I think that will help facilitate the rest of our discussion. And so I like to begin all my sessions talking about just how common cancer is in our population. They now estimate that 1 out of 3 of us will develop some type of cancer during our lifetime. That's primarily because we're living longer. So as we age, our bodies become more susceptible or more likely to develop certain types of conditions such as cancer. I think what this statistic really tells me, though, is that most, if not all of us, have a family history of cancer because it's so common in our population. Our job in genetics, in a nutshell, is to try and determine whether or not the cancers in that family are occurring by chance, just kind of a coincidence, or could the cancers in that family be related to one another and due to a hereditary factor that's being passed down in the family. And by hereditary factor, I'm referring to our genetic information, or the genes that we share in common with our relatives. So just to take a few moments to review these concepts, as you know, our bodies are made up of billions of cells, and inside the brain or nucleus of the cell are these small rod-like structures called chromosomes. And our chromosomes carry and organize our genetic information, or what we call our genes, which essentially are the blueprints for how we grow and develop. If I were to take a blood sample of any of you and look at it under the microscope, this is what we would see. It's a picture of your chromosomes. And again, they're in every single cell of your body. And we have 46 chromosomes, which is the normal number for a human being to have. And our chromosomes come in pairs, so they can actually cut the chromosomes out and arrange them by size, as well as the black and white banding pattern. And again, what we find is that our chromosomes come in pairs, numbered from 1 to 22, and then there is the sex chromosome. So we're looking at a normal female here, and we know it's a female because she has 2 X chromosomes as her sex chromosomes. Males are the same with the exception of their sex chromosomes. They have an X and a Y, but otherwise the numbered chromosomes are the same between men and women. And as I mentioned, the genes are located along the chromosomes, and they estimate that we have about 20 to 30,000 genes within each cell of our body. So it's a very intricate and detailed system. Now, I mentioned that our genes are really the blueprints for how we grow and develop, and our genes are composed of a DNA alphabet. And that alphabet consists of 4 letters, A, G, C, and T. And these letters occur in a sequence over and over again in that gene, and what they're doing is they're spelling out instructions for that gene and telling the gene how it's supposed to function in the body. So it's really important that these instructions be correct. If they are incorrect, then the gene cannot function like it's supposed to in the body, and that could result in various types of diseases. So when there's a change in the sequence or the alphabet of a gene, we call that a mutation. Just sort of a fancy term for change or alteration. Now, some mutations or changes in the gene actually are silent, and by that what we mean is there is a change in that gene, but it's ultimately not affecting how the gene is functioning in the body, and so it's not affecting that person in any way. And we all presumably have silent mutations. We just don't know about it because they're not causing us any harm. The mutations that we're concerned about are what we call disease-causing mutations, or deleterious or harmful mutations. These are changes in the sequence of the gene that do affect how that gene is functioning in the body, and it's these significant mutations that can result in diseases such as cancer. And so by definition, cancer actually is a genetic disorder. All cancer is genetic. And all we mean by that is that all cancers are caused by mutations or changes in our genetic information, like we just talked about. But by saying that all cancers are genetic, we're not implying that all cancers are inherited or passed down from one generation to the next. And so even though we often use these two terms to mean the same thing, in this case they are different, okay? And I'm going to explain that difference to you. In most people who develop cancer, no matter what type of cancer they have, they developed it because of a mutation or a change in one of their genes that they acquired during their lifetime. So they weren't born with that mutation. It's not a mutation that's running in their family, but rather due to maybe a lifestyle habit that they have, an environmental exposure during their lifetime, maybe a chance mistake occurred in one of their genes when it was dividing and duplicating itself. A variety of mechanisms can take place that cause that person to acquire genetic changes in their genes. And that would result, again, in acquired mutation, and that leads to what we refer to as sporadic cancer. This is the type of cancer that most people develop and the type that 1 in 3 of us will develop as we age. It's the result of genetic changes, but it's changes or mutations that we accumulate or acquire over our lifetime. So this is genetic because it's due to a genetic mutation, but the person acquired the change. It wasn't passed to them from one of their parents. They didn't inherit that change. Okay? That would be in contrast to this category. These individuals, rather than acquiring a genetic mutation during their lifetime, they're actually born with the mutation, most of the time because it was passed to them from one of their parents. So they inherited the mutation from their mother's egg cell or their father's sperm cell, and they were born with that genetic mutation or susceptibility. We call that a germline mutation when it's present when they inherit it. And these individuals then are predisposed to develop certain types of cancers during their lifetime. They're also at risk of passing that mutation to their own children. And so it's in these families that we start to see a pattern of cancer running from one generation to the next. And again, we refer to these as hereditary cancers. Remember, I mentioned sporadic cancer is where individuals are acquiring genetic changes over their lifetime. So in this picture, this individual was born with all of their genetic information intact and working properly. But during the course of his or her lifetime, we'll say it's a female, she acquired a genetic mutation in a lung cell, okay? So half the circle is shaded in. Now remember, our genes come in pairs, so we actually have 2 copies of each gene, okay? If you acquire a genetic mutation in one copy of the gene pair, it just means that you've lost the function of that copy. So this one is now lost, but you still have this other copy that's working properly and can compensate for the gene pair, its partner that's not working, okay? And so this person does not develop cancer because they have this backup copy that's protecting them. But they do have a hit, their first hit, we call it. And so if over the course of her lifetime, she acquires another mutation in the other copy of that gene pair, this particular gene is no longer functioning properly in the body because both copies of it have been knocked out. And this occurs randomly, oftentimes. So she now develops cancer in her lung, okay? But you can see that the mutation was just acquired in that particular cell type. It's just in the lung. That mutation is nowhere else in the body. It's not in the gametes, the egg or sperm cell, so she cannot transmit that mutation to her children. It's just affecting her and her lung. So again, illustrating in sporadic cancer, it is a genetic event because the cancer is caused by mutation, but she just acquired it and cannot pass it on, so it's not inherited. One of the red flags that we look for in families is whether or not there is early onset of cancer. And if there is, that could suggest to us that there may be something hereditary going on in the family. For most cancers, what early onset means is less than age 50. So for a breast cancer or a colon cancer, if that's diagnosed less than age 50, that's a red flag to us that this could be a hereditary family. It's not the only red flag, it's just one red flag, and we'll talk about what some of the other ones are in just a moment. But why would that be? Why would they develop their cancers at younger ages? It's in part because individuals who inherit a mutation from one of their parents, they are born like this. All of their genes have a mutation in it. So they're born with this susceptibility already. They're starting their life already with that first hit. That doesn't mean they're at risk for every type of cancer, though. It just depends. Our genes are like on and off switches. Some of our genes are only active in certain organs and are turned off in others. And so having a mutation in every single cell of your body does not mean you're at risk for every type of cancer. It would depend on which gene is mutated, and it would depend on what organs of the body that gene has a role in. Okay, but individuals who inherit a mutation, again, start their life like this. And so they only need a second hit to occur. They started one step ahead of everyone with sporadic cancer, and now only need to get a mutation in the other copy of that gene anywhere, and that results in cancer. And so this illustrates how in hereditary cancer, it's both genetic and inherited. Okay, it's due to a mutation, but since the mutation is everywhere, including the sex cells, this person can also transmit that mutation to his or her children, making it inherited or hereditary. Okay, so having said all of that and comparing sporadic versus hereditary cancer, I wanted to show you some statistics. And that is that sporadic cancer is the most common type. So 85% of all cancer cases are what we call sporadic. And again, by that we mean there is a genetic mutation, but that person acquired that mutation during their lifetime, and he or she is not at risk of passing that mutation down. This is the type of cancer that 1 in 3 of us will develop as we age. Only 5, maybe up to 10% of cancer cases actually are the hereditary or inherited type. So it's a pretty small proportion. I don't know if that surprises any of you. Most of our patients are surprised to learn that inherited cancer makes up such a small proportion. But I think that can be reassuring, because what it means is that even if you have a personal and or family history of cancer, the chance that it's inherited in your family is pretty small. But obviously for the families that are falling into this category, it can have significant implications for them and their relatives, which is why it's so important that we try to identify who these families are. There's a third category here I haven't yet mentioned called familial. It also accounts for about 5 to 10% of cancer cases. And these two are different. In familial families, what we notice is that cancer is clustering there more commonly than we would expect by chance. But it doesn't appear to be due to a single genetic mutation running in the family, but rather many genes that the family members share in common, as well as their shared environment. So those two things together to cause cancer in some families to cluster there more commonly than we would expect. So it's not a single genetic event that's causing the cluster, but many genes in the environment working together. Okay, and so how do we determine then who may be at risk for the hereditary type? We're all at risk for this, but how can we figure out who may be at risk for the type of cancer that's running in their family? And again, because it accounts for such a small proportion. It turns out that your family history is the best tool that we have, at least initially, to determine if you may be at risk for hereditary cancer. And so what we do when someone comes to the Cancer Genetic Counseling Service is we construct their family tree. In genetics, we call it a pedigree. And we use symbols like this to construct the history. Circles are females. These two are sisters. The vertical line going up would be to their parents. This is their father and their mother. This would be mom's siblings and dad's sibling. And then up another level, would be to both sets of grandparents. Okay. And so we construct a 3-generation, 1, 2, 3 pedigree on both sides of the family. And of course, we're obviously interested in who's had cancer in the family. And so we shade those individuals in, and we write their diagnosis below them. Individuals who have passed away, we indicate that by a diagonal line through them. Okay. And so we construct those pedigrees because we're looking for certain red flags or clues within the family tree that might suggest that the cancer in the family could be hereditary. And so on the far right here, we have an example of a hereditary cancer family. And the red flags that we see, this happens to be a breast cancer family, but this could be any type. It could be colon, it could be kidney, it could be ovarian. One of the red flags is seeing the same type of cancer in more than one relative. So we see the grandmother had breast cancer, her daughter, and now the granddaughter, okay? We also look for related cancers, and I kind of alluded to that earlier, that these hereditary cancer syndromes normally cause more than one type of cancer. In these hereditary breast cancer families, we often see breast and ovarian cancer running together. They're considered related. And so when we see those two cancers together in a family, that increases our suspicion also. And it turns out in this family that the granddaughter developed both breast and ovarian cancer. Another red flag, and arguably maybe the most significant one, is early age at diagnosis, which gets back to Glenn's question and comment. And for many cancers, that's defined as less than age 50. That doesn't mean that everyone who has a cancer less than age 50 has the hereditary type and everyone greater than that age does not. It's just a general trend that we see in these inherited cancer families. And so I don't think it takes someone in genetics to look at this history here and think there's something going on. You know, we've got 3 women all in direct lineage with one another, developing the same or related cancers, and all at young ages. Our suspicion would be that this family has one of these genetic mutations that's being passed down from parent to child. And so this would be in contrast to a more sporadic cancer family, where you might see one, or you could see a few affected relatives with cancer, but normally they will be developing their cancers later in life, 60s, 70s, 80s. And so from our perspective, we're not ignoring the cancer in the family, but since it's later onset, that would be more suggestive of something that is sporadic or acquired during that person's lifetime. It's the familial families that can be sometimes difficult to sort out, because oftentimes these families will exhibit some red flags of hereditary cancer. And so you're left wondering, is this just a coincidence that the grandmother and the granddaughter have developed breast cancer? Or is this the start of a pattern that we might see in this family over time? And so sometimes, again, these familial families, it takes a while for the history to reveal itself. In general, when we're looking at someone's family history, these are the features of hereditary cancer that we would be paying very close attention to. Do you have several relatives with the same or related cancers? Again, related, an example would be breast and ovarian. Another set of related cancers is colon and uterine or endometrial cancer. Those are considered related also. Younger age of onset then is typical, usually less than age 50. An autosomal dominant pattern of cancer. What that means is that there's at least one person in each generation affected. But sometimes we don't always see that pattern. Someone may have a small family or few women in the family. And so you don't have, since there are few women in the family, you don't have women to be developing ovarian cancer, for example. So there are some caveats to this pattern, and we might not see it all the time. the presence of very rare cancers, such as male breast cancer or thyroid cancer, if it's the medullary type. Those are considered rare cancers, and just the presence of that cancer alone would indicate that genetic testing is indicated. Individuals developing multifocal or bilateral cancer, so any paired organs like the breasts, the ovaries, the kidneys, was the cancer present on both sides, or was it unilateral disease? Someone developing multiple primary cancers, so it's not that they developed cancer once and the cancer came back, but new cancers. And we've seen individuals with 4, 5, 6 different cancers over their lifetime. And so you're left wondering, is there something in their genetic makeup that's triggering all the development of all those cancers? Some families were actually looking for non-cancerous features, such as colon polyps. There's a hereditary colon cancer syndrome that is also characterized by lots of colon polyps. So if we see those two things together in a family, we get suspicious. And then certain ethnicities, such as Ashkenazi Jews, and I'll talk more specifically about that in just a moment. Okay, one thing to keep in mind, though, is that family histories are always changing. They're dynamic. We're aging. New diagnoses may occur. So upon this person's initial history, her mother had ovarian cancer, which is a red flag for hereditary cancer, but you can see the family history otherwise is not that significant. It's just the mom. But a couple of years later, her sisters now develop breast cancer, and her brother has melanoma, the more serious type of skin cancer, and this history has now become more compelling. So it's important to keep that in mind. And normally when you go to their doctor, or your doctor, a lot of them are asking any changes to the family history from the last time that I've seen you, because they do change. Okay, and so just kind of key points from that section. Only 5 to 10% of cancer is hereditary, and we already established that in those families there's a single genetic mutation running in the family. And for that reason, genetic testing is not a screening test. We do not do genetic testing in every individual. And we'll come back to that point in just a moment as well. Your family history is the most important tool in assessing the risk for hereditary cancer. And just being aware of these 3 questions, being aware of that information in your family may allow you to sort of assess your own risk of hereditary disease. So who in your family has had cancer, what types of cancers are in your family, and around what age were the relatives diagnosed. Okay. And so now I wanted to move on and talk about one of the more common hereditary cancer syndromes. I think we've laid the groundwork and can now talk about a syndrome that will help further illustrate some of these issues. The syndrome is known as hereditary breast and ovarian cancer syndrome. And as with any type of cancer, most breast cancers, in fact, are sporadic, same with ovarian cancer, with a small proportion actually being inherited or hereditary. And the most common cause of hereditary breast cancer is due to this syndrome that I called hereditary breast and ovarian cancer syndrome. And that syndrome is due to mutations in these 2 genes, BRCA1 and BRCA2. Some people call them the BRCA genes. Have any of you heard of these genes before? Some of you have. And so it's not the gene that causes the syndrome. We all have the BRCA1 and 2 genes. It's whether there's a mutation in the gene. So remember, it's a mutation that causes cancer, not the gene itself. Okay, and so when genetic testing is performed, which is done using a blood sample, the laboratory would not be looking for these 2 genes in you because we all have them. It would actually be reading the sequence of your gene, that DNA alphabet that we talked about, to see if there's any misspelling or mutation. Now, what does it mean for a man or a woman? What does it mean if they have a BRCA1 or 2 mutation? Well, for women, their risk of breast cancer goes up to 87% if they have a BRCA mutation versus women in the general population. This is what we consider their lifetime risk. So by age 70, the chance that these women with these hereditary BRCA1 or 2 mutations may develop breast cancer is up to 87%. A related cancer to this syndrome is ovarian cancer, and these women are at increased risk for this type of cancer as well. The range is anywhere from 27 to 44%. That's, again, compared to the general population. So you can see that having these mutations increases the susceptibility. These numbers aren't 100%, but they're obviously many times that of the general population. So it's predisposing you during your lifetime. Now, we've had a lot of patients that come to our clinic. They've been referred by their doctor, and they say, well, I've already had breast cancer. What does my genetic status really matter? I've already had the disease. I was treated. I had a positive outcome. Why should I really care whether or not I have a BRCA1 or 2 mutation? Well, you just saw that she may be at risk for ovarian cancer if she has a mutation, and so that would have an influence on her medical management. But she's also at risk for a second breast cancer during her lifetime. This is not her original breast cancer coming back or recurring, but a new primary breast cancer. And that risk is as high as 64% during her lifetime. So we're now seeing a lot of women, more than ever before, who have just been diagnosed with breast cancer, and they're in the process of making a surgical decision. And we're now seeing them a lot more during that process, because if they're positive for a mutation, some of them are considering having both of their breasts removed, the one for treatment and the other one for prevention. So it is playing a role, like a real-time role in women's decision-making following a diagnosis. Now, unfortunately, men are not safe from this syndrome either, this hereditary breast and ovarian cancer syndrome. These mutations can be inherited and passed on by both men and women. And men could develop cancer as well. We see male breast cancer increased in these families, as well as prostate cancer. And then both men and women with a BRCA1 or 2 mutation, they have a higher risk of pancreas cancer, as well as melanoma, the more serious type of skin cancer. So we consider all of these cancers I just mentioned to be related: pancreas, melanoma, prostate, male and female breast cancer, and ovarian cancer. And so if we see a constellation of tumors in a family involving any of these, or more than one of these, those are considered related, and that would be a red flag for us. If we do identify that there is a mutation running in the family, it does then allow other relatives in that family to undergo genetic counseling and testing. So if we know there's a specific BRCA1 or 2 mutation in the family, other relatives in that family who are at risk can be tested to see if they have it also. And then I'm not going to go into great detail about how to manage these patients, but there are recommendations that we discuss with our patients based on knowing that they have this increased susceptibility. We talk to them about increasing their surveillance, the potential of prophylactic or preventative surgery, or taking medications to reduce their cancer risk. So we have a full balanced discussion about all of these options based on their genetic testing result. Okay. And so this slide, is indicating the red flags for this particular syndrome. The other slide was just red flags in general for hereditary cancer. This would be specific to hereditary breast and ovarian cancer syndrome. So when we're analyzing a family history, there are many different cancer syndromes, and we would be looking at the red flags in their family to see which syndrome, if any, that family history may be suggestive of. And if we were to see any of these red flags in a particular family, then it's this syndrome that we might be suspicious of. And I wanted to talk about that Ashkenazi Jewish issue in individuals who are Ashkenazi Jewish, these are men and women who originate from Central Eastern Europe, and 90% of American Jews are Ashkenazi. These individuals are at a higher risk of having these mutations. It's estimated that 1 in 40 Ashkenazi Jews will have a BRCA 1 or 2 mutation. That's compared to about 1 in 400 individuals who are not Ashkenazi, of other ancestries. So this is considered a red flag. If you're of this ancestry, this is automatically a red flag for your family history. Some misconceptions about the family history as it relates to breast and ovarian cancer. One is, and we're still hearing it in clinic, patients are being told that cancer on the father's side of the family doesn't count. That family history I just showed you illustrated this is completely wrong. Half the time, if it's hereditary, it's coming from the father's side of the family. That's why when someone comes to our clinic, we take a full family history, including both the mother and father's side. Another misconception is that ovarian cancer in the family is not a factor in breast cancer risk. That's not true either. Ovarian cancer is a pretty significant red flag for this particular syndrome. And the last one is that the most important thing in the family history is the number of women with breast cancer. That's not true. It's really the age of onset. So if you've got 4 women in your family with breast cancer, but they all developed it in their 70s and 80s, that would be less compelling when compared to a family history where you might have 2 breast cancers, but they've occurred in the 30s and 40s. So it's really the age at diagnosis that tends to be more significant than the number of women affected. Okay, so key points on that section, and I'm just about to wrap up. Hereditary breast and ovarian cancer syndrome accounts for about 5 to 10% of all breast and ovarian cancer cases. It's caused by mutations in the 2 genes, BRCA 1 and 2. And we determine when genetic testing is appropriate based on careful assessment of the family history and the personal history. But some families don't present with classic red flags. We had that woman who didn't develop breast cancer till 73, and yet she still had a mutation. And so we have to keep those things in mind. And our suspicions of having a mutation may be higher in certain situations. So in Ashkenazi Jewish families, our suspicion may be a little bit higher. When there's a family that has few females, we may be more suspicious depending upon the red flags if there are few women in the family to be developing those cancers. If you have a very young family, maybe you're seeing someone in your clinic who's 25 with breast cancer and her mom's only 45. Well, maybe her mom has not developed the cancer yet because she's still a little bit young. Triple negative breast cancers is a red flag for this syndrome. That's looking at features of the breast cancer itself. There are hormone receptors that can be tested for, and if those are negative, that appears to be a red flag for this syndrome. And of course, it's important to remember that this syndrome can be inherited from the paternal or the father's side of the family. So when should genetic testing be considered? Obviously, if someone comes through our clinic, we take a detailed family history, we're looking for red flags, and determine if genetic testing may be appropriate based on our assessment. And genetic counseling, of course, is an integral part of that process. Genetic counseling is just having the discussion. In fact, a lot of things I'm talking to you about today are things that I talk about in my genetic counseling sessions. It's just educating the patient about their family history and the option of genetic testing. And just because someone comes in and has genetic counseling doesn't obligate them to have testing. They're really 2 separate things. The counseling is assessing the family history and determining if testing is appropriate, and if so, that would be the next step. I mentioned when counseling those 2 young women, the daughter that was negative actually felt guilty. We call that survivor guilt. She felt bad that she had been spared. And that is a common reaction. So being negative certainly is good news, but there can be some psychosocial reactions to that result. And for some people, actually being positive is empowering to them because they've been living with just a horrendous family history for so many years and never knew what the cause was. And when we can determine that there's one of these mutations in the family, at least they know what is causing the family history. And for some of them, that, of course, relieves uncertainty, but empowers them a little bit because now they know moving forward. So points to remember: genetic testing, while it is a blood test and it is available, it's not a test that we recommend for everybody. It's, again, based on personal and family history. These tests are rather expensive, too. They can be $4,000 or $5,000. So that's also why it's not just a general population test that we would do on everybody. It would not be cost effective to do it that way. I just wanted to mention there have been some concerns, at least in the past, that if you have genetic testing, could your result be used against you? Could you be discriminated against by your health insurance, for example? Could they say, well, you don't have cancer, but you have this mutation and it's predisposing you to cancer, so it's a pre-existing condition, for example. And that's the definition, again, of genetic discrimination would be for someone who does not have a diagnosis of cancer themselves, but they have one of these mutations that they learned through genetic testing. Could that be considered a pre-existing condition? And the answer is it's illegal. We have federal laws that protect people against such discrimination, and there have been no well-documented cases of genetic discrimination nationwide. Now that relates to health care coverage, and HIPAA is one of the laws that protects people. We often think of that as a privacy act, but it also has protections with respect to genetic testing. And the other one, more recently, that was signed into law by President Bush is the Genetic Information Non-Discrimination Act. This also has protections in place for health care coverage, but the difference with this law is that it also added employment coverage. So you could not be discriminated by your employer because of a genetic test result. We do not have any laws that provide protection with respect to life insurance. So we have advised patients, if they do not have life insurance in place before testing, that may be something that they want to have in place. That way, they would have that already secured before receiving a result. And that's just because we don't know the ramifications of the possible discrimination that could occur. And ultimately, I think what we try to explore with our patients through the counseling process is, do you really want to know this information? Because once you know, you can't not know. There's no going back. And for some people, it opens up a Pandora's box. And some people decide that maybe now is not the best time. They have other things going on. Maybe they're actively being treated for their cancer and they want to get through that and maybe come back and talk about it after. So again, just through the counseling process, we try to explore with the person what they hope to do with the information and how it may be beneficial to them. And some may decide to wait. And some decide not to pursue testing ever. So it's a very personal decision. So we would say anyone with the following would be appropriate candidates for genetic counseling. Many of these are red flags that we've talked about. But I also like to say anyone that has anxiety and or concern about their cancer risk is an appropriate person for genetic counseling, because often what we are doing is providing reassurance. Many people's perception of their cancer risk is much higher than it actually is. And through the counseling process and through the risk assessment that we do, we can alleviate some of those concerns for our patients. These are the things that we do when people come for genetic counseling. Again, compilation of that 3-generation pedigree. We then do our risk assessment where we're determining the likelihood that they may be at risk for hereditary cancer. And if so, talking about genetic testing and facilitating all of that. We also do discuss the costs of genetic testing. We try to help investigate insurance coverage for the testing. So all of that is in place in order for the person to be able to make an informed choice about the test. This is the staff that I work with here at Karmanos. Dr. Michael Simon is the director of the Cancer Genetic Counseling Service. Tessa Paling is a genetic counselor that just joined our team in the summer, and Wanda Sheard is our administrative assistant. And we do have clinics downtown here at the main campus, as well as Weisberg Cancer Treatment Center in Farmington Hills. And so again, just kind of summarizing everything, I think it's really important to keep in mind that only 5 to 10% of cancers are hereditary, or the type that are running in families. And for that reason, genetic testing is not a screening test for the general population. We do have to go through this risk assessment process to determine who is appropriate for testing, and then if so, which genetic test is most appropriate based on the types of cancers that we're seeing in their family. And that we should consider it when a patient has a reasonable likelihood, of course, of curing a mutation, et cetera. We also keep in mind that not all inherited families are classic. Not all of them present with these red flags. There are caveats to genetic testing, and then we all have an important role in identifying at-risk individuals just by being informed about your own family history and discussing that history with your doctor. And so I like to end with this slide. This is for all of us. I feel like I'm in David Letterman now. The top 10 reasons to know your family history. Number 10, it's a free medical screening that you can do in the privacy of your own home. Number 9, it's a great way to get to know your relatives in older and younger generations. Number 8, it's a good way to know your risk for conditions seen in relatives. Number 7, because when you need to know, they may not be there to ask. Number 6, because with a little help from the past, you can change your future. Number 5, because it's not just recipes that get passed down in families. Number 4, it's a priceless gift to leave to your children. Number 3, it doesn't cost a thing and it could save your life. Number 2, because what you don't know can hurt you. And number 1, because every family has a story, but not every family has your story. That's it.
So beautiful.
Oh.